that okay?
Good evening, everyone. I hope everybody can hear me. So I want to thank you so much for joining us for tonight's webinar, What Women Want to Know About IBD. I want to extend some thanks out to our sponsors as well. The lovely folks at Alpha Sigma and AbbVie were kind enough to sponsor tonight's webinar, so thank you to them. My name is Alicia Barron. I'm the Education Manager here in Texas and Louisiana, and I am joined tonight by Dr. Sonia Friedman, who will be presenting this webinar. Dr. Friedman is the Director of Women's Health at the Crohn's and Colitis Center at Brigham and Women's Hospital in Boston, and she is an IBD expert and frequently is referred very complicated cases of IBD. Her research is focused on women in IBD, specifically around fertility and pregnancy and hormones and sexuality. So she's the perfect presenter for tonight. In addition to being a clinician, she's a well-respected teacher, author, and lecturer, and I know frequently goes out and gives talks at all over the country and internationally as well. She is a longstanding member of the chapter advisory, the medical advisory committee in New England, and was the former chair a few years back, I believe. And I can attest to her generosity and she frequently extends to the foundation, and she's always very enthusiastic about these opportunities. So I am delighted that she's able to join us tonight. You guys are going to have the opportunity to ask some questions of Dr. Friedman after she's done with her presentation. So what I want you to do is you're going to look in that control panel, and there's a questions section. In that section, you can type in any questions that you have, and I'll be reading them to Dr. Friedman after she's done with her presentation. So I am going to turn control over to Dr. Friedman, and she's going to present her slides. So thank you so much, Dr. Friedman.
Are we good?
You are presenting.
Okay, so today you can see my slides okay?
I can.
So today I'll be talking about women and inflammatory bowel disease, and I want to thank you very much for having me today. It's really my pleasure to talk about these issues. So I just wanted to give you guys just a brief background on ulcerative colitis and Crohn's disease, because these diseases have become more and more common over the last 50 years. And the peak incidence is in young people, ages 15 to 35 years, and more than half of the IBD patients are women. The diseases have an unpredictable pattern of relapses and remissions. And as you know, a relapse is really characterized by inflammation of the small or large intestines. Relapses can be characterized as mild, moderate, or severe. So the symptoms of ulcerative colitis, as you know, are bloody diarrhea, abdominal cramps, urgency to use the bathroom, weight loss if the disease is very extensive, like the whole colon is inflamed, fevers, and again, the symptoms really vary with how severe the disease is and where it is. If a patient just has disease of the rectum, she'll present with bleeding and constipation, but if she has disease of the whole colon, she'll present with more severe symptoms. So this is a colonoscopy just showing the degree of severity of ulcerative colitis. And the first one is normal. The second one is mild disease, then moderate, and then severe. And severe disease often requires hospitalization and steroids and more serious medications. The symptoms of Crohn's disease are more insidious. They take a little bit longer to develop. Diarrhea, chronic abdominal pain and tenderness, weight loss, fevers, and it's important to check for perianal disease, such as fissures, skin tags, fistulas, abscesses. And again, the symptoms really vary with the location of disease. Crohn's disease can occur anywhere from the mouth all the way to the anus. The most common location is the end of the small intestine. These are the features of Crohn's. Most patients present with inflammation, abdominal pain, tenderness, diarrhea, and weight loss, and then either evolve to obstruction or scarring, or fistulization, which is a connection from one organ to another. For example, bowel to bowel, bowel to skin, often rectum to vagina, or perianal fistula. So tonight I'm going to be talking about many things that have to do with women and IBD. The first, just what type of birth control should patients use? The second, which is kind of a new topic, is sexual function or dysfunction in IBD. The third is fertility. Is there decreased fertility in IBD? The fourth is planning a pregnancy. What should women and men know when planning a pregnancy? managing IBD during pregnancy? What about all these medications that everybody's taking these days, like Remicade and Humira, steroids? Delivery recommendations, should you have a vaginal delivery or C-section? And then management of the IBD after delivery and breastfeeding. So first I wanted to start with contraception. Will certain types of contraception make IBD worse? Contraception use should not worsen bowel symptoms and may actually improve them if they're cyclical, because a lot of women do flare around their periods. Contraception is effective in IBD. And again, planning pregnancy is crucial. You want to get pregnant at the right time in your life and your disease. Are there any contraceptive methods that should not be used? So if women have significant inflammation affecting absorption, like significant inflammation of the small bowel, which absorbs all your nutrients, this can make the birth control pill less effective. Women with IBD also have a 2 to 3-fold increased risk of blood clots, of clotting, especially those with active IBD, with flares, with inflammation. And birth control that contains estrogen can also increase the risk of blood clots. IUDs in general are safe, and they're actually a great form of birth control for women with IBD. So in terms of the risk of hormonal contraceptives, for regular contraceptives, for low-dose birth control pills, for a hormonal patch or a vaginal ring, if you have mild IBD and no other risk factors, no flares, no family history of a blood clot, the benefits generally outweigh the risks. So a lot of my young female patients are on birth control, no problem. For women with IBD who are at increased risk of blood clots, so these are if you have a family history of IBD, if you have an active disease flare, or if you've just had surgery, it's really not great to take hormonal contraceptives because the risks outweigh the benefits. And that's a pretty simple explanation. So I wanted to move on to IBD and sexual function. Now, the reason I started being interested in this, because I started asking my patients about it, and I found that many had trouble, many women and men, but we're talking about women tonight, had trouble with sexual function, especially painful intercourse. And the word we use for that really is dyspareunia. And many things can affect sexual function. For example, a disease flare, you're not feeling well because your disease is flaring. Medications such as steroids, narcotics, antidepressant medications, surgery, for example, the ileal anal J-pouch surgery for ulcerative colitis, or an ostomy, for example, and depression is a biggie that can affect sexual function. So what we know about sexual function in Crohn's disease and ulcerative colitis is that there is increased sexual dysfunction in women with IBD. We know the causes, which I just explained, and we know how to treat it in women without IBD, but I want to kind of bring this over to women with IBD. What we don't know is how to accurately measure the presence of and the degree of sexual dysfunction in women with IBD, and really how to treat it. So these are all the factors that can affect sexual function. For example, disease activity or flares, diarrhea, fatigue, low libido, body appearance or image, perianal disease, for example, perianal fistulas or fissures or abscesses, skin or joint swelling or pain, medication use, for example, corticosteroids, which can affect body image, or opiates like morphine or Dilaudid or narcotics. Depression can affect sexual function with reduced self-esteem, anxiety, and antidepressants. And surgery can as well, with scars or ostomies, feeding tubes, pain, nausea. So I want to try and help people with this problem. So we did a questionnaire study to IBD female and actually male patients at our IBD clinic, and we asked them what was most worrisome about sexual function, and this is what we found. And the bottom is just the percent of patients who indicated they had this issue. So if you look, many patients were embarrassed, they felt less attractive, they feared pain, they feared passing gas, they were distressed, etc. And the main thing is just to discuss this with your doctor, and doctors should be asking you about it also. So what we do, which we found really helpful, is that if you have dyspareunia or painful intercourse, we send patients for pelvic floor physical therapy with an experienced therapist for sexual dysfunction. And what the therapist will do is do myofascial release at very specific vaginal and pelvic trigger points. She'll do biofeedback therapy, vaginal dilators, and also when talking to patients, I try to assess their mood, is there depression, are there stressors, does the patient need a therapist, for example, or GYN, if there's more a vaginal issue, a dermatologic issue. So there definitely are treatments. And this is actually very effective in my patients. So this is kind of the algorithm I look at. First, I try to see if the patient's depressed or stressed, abused on certain medications like steroids. I'll send them for a GYN exam, manage active GYN issues and IBD issues. And then depending upon the disorder, either pelvic floor physical therapy or counseling. And actually, this is incredibly helpful. And I think the biggest barrier in patients and doctors are worse than patients in talking about it, is really just bringing it up and discussing it. So I want to move on to IBD and fertility. It's really hard to measure fertility or the ability to get pregnant in women with IBD because it's very hard to measure how many women are actually trying to get pregnant because women are on birth control. Some women have this phenomenon called voluntary childlessness or volunteering not to have children because they're afraid of passing on genetic defects or afraid of passing on, IBD or afraid of not being able to care for their child. Other things that can affect fertility are disease flares, medications, surgery, and ovarian reserve, which I'll go into a little bit later, which is a little tricky. So in terms of fertility, what we know is that there's increased voluntary childlessness, women volunteering not to have children. And I think education really will fix this because it really is safe to be pregnant and have IBD. I mean, most women do incredibly well. We do know that IBD surgery decreases fertility, especially pelvic surgery, which can scar the fallopian tubes. For example, an ileostomy or an ileoanal J pouch. What we're beginning to understand is that laparoscopic surgery may preserve fertility. So 20 years ago, surgeons made these big incisions, they did these major surgeries, but laparoscopic surgery is just little scars, and women do better, and fertility really is preserved. In vitro fertilization is definitely an option after surgery if there's scarring of the fallopian tubes. It may not be as effective in women with IBD, but I'll go into that a little bit later. Patients with Crohn's disease especially may have decreased ovarian reserve, and patients with active disease, active flares probably have decreased fertility, so you want to treat the disease activity. So first I just want to kind of explain what ovarian reserve in Crohn's disease is. So ovarian reserve is the capacity of the ovary to provide egg cells that are capable of fertilization, resulting in a healthy and successful pregnancy. So basically, healthy ovaries, healthy egg cells. The way we measure this, and this is pretty cool, and any GYN doctor will measure this, is you can get a blood test called anti-Müllerian hormone, or AMH, and it's a good indicator of ovarian reserve. So when researchers measured this blood test, they found that low ovarian reserve was really in Crohn's patients and associated with an older age, more than 30, colon inflammation, more disease activity, longer duration disease, and that surgery did not really affect it. So this, I think you guys are familiar with. This is an ileoanal J pouch anastomosis, and this is the major surgery that is done for ulcerative colitis. The colon is removed and the end of the small intestine is looped into a pouch and sewed to the anal rectal junction. So you're continent. There's no permanent ostomy. This is a great surgery and it works really well in curing ulcerative colitis. Fertility is decreased after this surgery, mostly because it was a laparotomy. It was a major surgery. There used to be a lot of scarring of the fallopian tubes. researchers 10, 15 years ago found a 2 to 3-fold increased risk of infertility after the surgery. In fact, fertility was reduced from 72 to 37% after surgery. But more recent studies, in the past 10 years, have shown that if you do laparoscopic surgery, fertility is a lot better, close to normal. So there's a lot of hope with this surgery, and I certainly wouldn't delay surgery if you're worried about infertility. And if you're healthy, including having the surgery, you're more likely to get pregnant and have a healthy baby. And in vitro fertilization, or IVF, is a good option because it bypasses the fallopian tubes and patients have good outcomes. So when should we refer for in vitro fertilization? I see patients pretty much not infrequently who have trouble getting pregnant. And they say, should we go to a fertility specialist? Well, these are my guidelines. If there's been more than 1 year of infertility in any IBD patient, I will send them to a specialist. Any IBD patient with irregular cycles who has had surgery, because again of the scarring of the fallopian tubes, I'll send them to a specialist. And a patient who has an ileostomy, which is permanent, or a colostomy, which is permanent, or a J-pouch, and has tried more than 3 months and is unsuccessful, I'll send them for IVF. Now, I did studies in Denmark because in Denmark, there's a really wonderful national database. All people who have healthcare have to register in the system. And so there's a birth registry and actually an IVF registry. So we can actually see all the patients with Crohn's and colitis who have had IVF. And what we found in Denmark is that the live birth rate in women with ulcerative colitis who had IVF was lower than women in the general population. And this was the same with Crohn's disease, and especially Crohn's disease surgery. So women didn't do as well in Denmark. We also did studies in the United States and found that women did better. And I just think it's because IVF is probably better in the US. But I would encourage you, if you are able, and if you're unable to get pregnant, IVF is definitely a good option, especially in patients who've had surgery. So to conclude about fertility, aside from this increased voluntary childlessness, there is decreased fertility in IBD. And it's mostly due to surgery and probably increased disease activity. Patients with Crohn's probably have decreased ovarian reserve. Laparoscopic surgery probably improves fertility, especially in patients who've had surgery. And women with IBD, at least in Denmark, do not have the same success with IVF as women without IBD. So now I'm going to move on to pregnancy. That's a really big topic, especially with all the new medications we have. Patients and doctors have to consider so many things, including medications, the adverse effects, adherence to medications, surgery, disease activity during pregnancy. So what is the impact of Crohn's disease on pregnancy versus ulcerative colitis on pregnancy? And basically, you want to be in remission before getting pregnant. So if you're in remission before getting pregnant, the odds are you'll have a healthy pregnancy. For patients with Crohn's, the disease activity during pregnancy is about the same as disease activity when you're not pregnant. So Crohn's is good. Women with ulcerative colitis tend to flare more during pregnancy. And that is pretty much throughout all the studies that have been done, even if they're in remission when going into pregnancy. You can see in this graph that these are non-pregnant patients with UC and pregnant patients with UC in the pink. And the pregnant patients were less likely to remain in remission. Now, what's the impact of pregnancy on the IBD? Well, if a patient is in remission at the time of conception, there's about a 70% chance that she'll be in remission during the pregnancy, and a 30% chance that she won't. If she has active disease, and this is what we really try to prevent by staying on stable medications and seeing your doctor, talking to your doctor, staying on medications, and most medications are safe during pregnancy. There's a 30% chance she'll flare during pregnancy, and a 30% chance she'll be in remission during pregnancy, and a 70% chance she'll flare. And the worst thing for an IBD pregnancy is a flare. The main goal is to stay on stable medications, adhere to medications, and prevent a flare. So this was a study that was done with preconception care. This was a clinic actually in the Netherlands, And the researchers did something really interesting. They took two groups of patients. One group where they counseled for 30 minutes, these were women with IBD who were going to get pregnant. They counseled them for 30 minutes just on pregnancy and IBD and staying on their medications. And the control group did not receive counseling. And just with 30 minutes of conversation, the study group, or the group that had the counseling, did better. They were more likely to take folate, which we need for pregnancy, more likely to stop smoking, less likely to discontinue their meds, and less likely to have disease activity during pregnancy. So why don't we want disease activity during pregnancy? Because we want to prevent possible adverse outcomes. Low birth weight and preterm birth are the main predictors for perinatal mortality and morbidity. And disease activity, increased flares during pregnancy, increase the risk of low birth weight and preterm birth. Impaired intrauterine growth, so small babies, impaired growth predicts chronic diseases in adulthood. So our goal really is to calm down the disease and stay on stable medications. So this is a study that looked at pregnant women who were hospitalized, pregnant women with IBD who were hospitalized in the United States. And the researchers looked at over 4 million deliveries, more than 2,300 with Crohn's, and more than 1,300 with UC, and found, and these were pregnant women with IBD in the hospital who were sick. And they found an increased risk of C-sections, blood clots, blood transfusions, and malnutrition. So it's really important to keep patients out of the hospital. So let's look at the treatment of inflammatory bowel disease in the past, 20 to 5 years ago. Biological therapy, such as Remicade, Humira, Cimzia, and Entyvio, was considered only for those who had moderate to severe disease or failed other medications. And it was introduced in the 90s. You probably remember the days where most patients were given 5-ASA drugs like asulfidine or Azocol, then if they failed, then prednisone, and then if they failed, 6-MP, and then if they failed, Remicade. Well, the strategy is completely changed now, and I think for the better. People do better these days with fewer hospitalizations. So what's treatment of moderate to severe IBD in 2018? Biologics plus 6-MP or azathioprine, and if that fails, prednisone for flares, and if that fails, total parenteral nutrition or novel therapies. There's a lot of new therapies coming along, and then surgery. But the mainstay of treatment for IBD, UC, and Crohn's is really biologic therapy. So we have many biologics, we have many new treatments, but not a lot of data on pregnancy. Look at all these drugs: Remicade, Humira, Cimzia, Entyvio, Tysabri, Stelara. Xeljanz is a new one. It's a pill that you take for rheumatoid arthritis, which will be soon approved for ulcerative colitis. So I wanted to show you a little data with these drugs on pregnancy. I think it's really important to discuss pregnancy with patients who are planning to conceive in the near future. You really want to discuss disease status at conception, which should be in remission, and then the continuing of medications, most of which are safe. And it's often recommended to meet with a high-risk OB. If a patient is on steroids, if a patient is flaring, if a patient has had surgery, if a patient is on a biologic such as Remicade, she should meet with a high-risk OB. So to summarize, in terms of the safety of medications during pregnancy, oral and topical ASAs like Azocol, Lialda, Aprezo are safe. Steroids are safe. Metronidazole is safe in the 2nd and 3rd trimester, and most medicines for diarrhea are safe. 6-MP, azathioprine look to be safe. Cyclosporin, not enough data, and it's an old medicine anyway. The anti-TNFs, anti-tumor necrosis factor medicines, and those are Remicade, Humira, and Cimzia are safe. Vedolizumab, which is Entyvio, and ustekinumab, which is Stelara, are safe. You don't want to take Azocol HD because it has something in the plastic coating surrounding the pill called diphenyl phthalate, which may be toxic. Methotrexate, and thalidomide. So a Remicade and Humira is safe during pregnancy. There are about 50 studies of these drugs during pregnancy over the past 10 years, and all these studies look good. with no birth defects, no preterm births or early births, no low birth weight, and they all look very safe. So we do tend to continue these medications during pregnancy. This is just one study, which is a summary of other studies that I'm showing you. So the deal with Remicade and Humira, or infliximab and adalimumab, is that they actually cross the placenta to the baby, and that's in the second trimester. So if you look at this graph, this is 20 weeks of pregnancy, and these are the drugs, Remicade and Humira, and they actually cross the placenta with maximally in the third trimester. Certolizumab or Cimzia diffuses across the placenta. It isn't actively transported, and the levels are much lower. So when do you stop these drugs? When do you stop Remicade and Humira? It depends where you live, really. In Europe, the Europeans tend to stop at around week 24 to 26. In London, about the same. In the US, we often continue these medications through pregnancy. If a woman is not flaring and in remission, we'll typically give the last dose at 30 or 32 weeks. If a woman is flaring, we'll continue these drugs throughout pregnancy. How long are the levels detectable in the baby? And that's the question. So if Remicade and Humira cross the placenta to the baby, how long can you detect them after birth? And this is a graph of adalimumab or Humira and infliximab or Remicade. And you can see it almost goes up to a year. I think there was one baby with each of these drugs that had levels in their blood at a year. In terms of the other drugs, Entyvio, which is used more and more now, there's not a lot of data. I'm showing you the data that's out there. There's 24 pregnancies in women and 15 pregnancies in men who took the drug. You know, their partners became pregnant, and it was pretty safe, one congenital anomaly. So we do tell patients to continue this drug during pregnancy, with the last dose being about 30 or 32 weeks, and then immediately after delivery. For Stelara, even less data, but again, we consider it safe. The maternal fetal medicine doctors are recommending to continue it with, again, this is an every 8-week drug, so the last dose would be at about 30 or 32 weeks, and then right after delivery. Now, tofacitinib or Xeljanz, I'm not sure if you've heard of this drug, but it's fairly new, and it's about to be approved in ulcerative colitis. It's a pill that you take, and there's really not a lot of data. And we're not recommending continuing this drug during pregnancy right now. It's used for rheumatoid arthritis and psoriasis, and there just aren't a lot of pregnancies. We just don't have a lot of data. And this is the data in ulcerative colitis. But we wouldn't recommend it for now. It isn't yet approved, and we just don't know enough. So what about breastfeeding? Well, there's so many benefits to breastfeeding, and we recommend it if possible. There's reduced infant infectious diseases, reduced diarrhea, reduced ENT infections, reduced pneumonias, reduced long-term risk of asthma and obesity and SIDS, reduced maternal breast and ovarian cancer, and the healthcare costs are lower. So we do want our moms to breastfeed. But are these drugs safe? It turns out, yes, they are. All these drugs are safe in breastfeeding, and I'll show you that a little more later. So one of the big questions in pregnant people is, how do you evaluate a disease flare during pregnancy? A lot of patients have abdominal pain, loose stools, or constipation, or low-grade fever during pregnancy, but is it the IBD? What's the best way to measure it? Well, we can do blood tests, and one of those blood tests is called a CRP, but that's not accurate. There is a study, a stool test called fecal calprotectin, which is a very accurate measure of disease activity during pregnancy. So if you're not sure, it's something good to ask your doctor about. It's called fecal calprotectin. So how do you manage a patient who's flaring and pregnant? Well, the mainstay of treatment really is prednisone for acute flares. It's okay to start Remicade or Humira during pregnancy. You want to always check for infection, check for C. diff and bacterial infections. In terms of imaging, a lot of my patients are afraid to get an MRI, but it's very safe during pregnancy. You just don't want to get the IV contrast, the IV gadolinium, but MRI is fine, and ultrasound can be very helpful to detect a flare during pregnancy. For endoscopy, we sometimes do an endoscopy just to check the lower colon to see if someone is bleeding without sedation. And that is safe also. If a patient unfortunately needs surgery, we can do that during pregnancy, and the second trimester is the best with really good outcomes. So what about delivery? Most patients with IBD can have a normal labor and delivery. For patients with ilioanal J pouches, that's the operation for ulcerative colitis, we caution against vaginal delivery because there's a higher incidence of fecal incontinence, of defects of the anal sphincter. So although there can be good short to medium term function of the J pouch, long term we're not so sure. So many of our patients really do opt for C-sections. The absolute indications for C-section are active perianal disease, perianal fistulas, perirectal, rectal vaginal, or perianal fistulas. So after delivery, we want to immediately restart medications such as Remicade and Humira and Entyvio in the hospital. In terms of the vaccine recommendations, they're in the next slide, and most medications are safe during breastfeeding. So these are the vaccines. You can see you want to give the baby inactivated vaccines if they've gotten Remicade or Humira or Entyvio. Hep B is good, DPT is good, Hib is good, PCV, IPV is good. The rotavirus is a live vaccine, and that's usually given at 2 months, 4 months, and 6 months. So we tend not to give that. You can check the baby's Remicade levels or Humira levels to see if they have it in their system to see if you want to give the vaccine. But in general, we do hold this vaccine. So what about the safety of medications during breastfeeding? Well, most of them are safe. The ASAs like Isocol, Lialda, etc. are safe. Sulfasalazine is safe. Steroids are safe. Azathioprine, 6-MP, Remicade, Humira, Cimzia, Entyvio, Stelara are safe. We don't give methotrexate, metronidazole, Cipro, or cyclosporin. So to summarize, the best outcomes for women with IBD are those with planned pregnancies, those in remission. You really want to ensure preconception counseling and collaboration with an OBGYN or maternal fetal medicine before and during pregnancy. We don't alter best practices for IBD management due to pregnancy in women with active disease. In fact, I treat more aggressively in pregnant women. We don't want to stop their Remicade or Humira. We give steroids if they have a flare. Just remember, infliximab has a lower clearance from the baby's circulation, and as well as adalimumab does too, and you can have levels for up to 12 months. If you do combination therapy with Remicade and azathioprine, it's associated with a greater risk of infections. Thank you very much. And now I'm happy to take questions.
Great. Thank you so much, Dr. Friedman. That was a lot of information and really awesome. So I'm going to invite everybody to go ahead, and if you look in the control panel, you'll see the questions box. Please feel free to type your questions in there. But while we're waiting for some questions from the audience, I'm going to start out with a couple of mine because I certainly was taking a lot of notes when you were talking. So I know you talked a lot about sort of ways to make sure that we're maintaining and reducing that disease activity during pregnancy, and a lot of that about medications. I'm curious, I know a question that we're going to get from the audience is, are there other types of things they could be doing, maybe some supplements or a specific maybe dietary considerations that they could be doing that also might help keep their disease in check and them healthy while they're pregnant?
Yeah, I mean, rest, sleep, relaxation, vitamins. I really do like vitamins. Make sure you're not anemic. If you need to take iron, oral or IV, B12 if you're B12 deficient. Folate is a biggie, especially you need 1 milligram a day. If you have malabsorption, you need more. If you're on sulfasalazine, you need more. Vitamin D is very important. A healthy diet is very important. There's no particular diet that's going to help you specifically during pregnancy.
Okay, perfect. So it sounds like talking to your doctor and getting those your all of your levels checked, like your B12 checked and everything like that would be really good. Okay, excellent. So my other questions, I'm going to back you up a little bit into birth control. So you mentioned that sometimes this birth control can be a little less effective. I'm curious if there's a way to check to see if perhaps you're not absorbing your birth control and therefore it's not as effective. Is there a way to test that?
Yeah, it's tricky. It's very tricky. I don't know how to test that. I've often wondered how to test that. I would say if you have a lot of disease of the small bowel, like extensive, a lot of disease in the ileum, you're on a lot of medications, you're having diarrhea, you're losing weight. You also have low vitamin levels like D and B12 and anemia. And I would tend not to give the pill because I really would be afraid of malabsorption. If you have an ileostomy and you're having high output, or if you have a J pouch and you're having a lot of diarrhea, I would be a little worried about taking the pill. You may want an IUD or a vaginal ring or a patch.
I'm curious, so some of the IUDs are the copper IUDs that don't have any hormones, and some of them do have the hormones. Is there a difference between the two IUDs? Is there one you would recommend over the other? Do you still have malabsorption issues with the hormonal IUD?
No, I mean, it's interesting. It's like patient preference, and the GYNs will put all of them in, but it's really the preference. I mean, if you don't want to bleed a lot and cramp a lot, it just really depends. There's no impact on the IBD. It's completely safe. And you can be on steroids, you can be on biologics, you can have surgery. IUDs are safe.
Great. I'm curious, you mentioned that IVF is effective for people with Crohn's and ulcerative colitis because it bypasses the fallopian tubes. Is there a theory as to why that's the case? Is there something about the fallopian tubes?
When you have surgery, like really extensive pelvic surgery, and inflammation on top of that, you can get fallopian tube scarring. So if you do imaging, it's called a hysterosalpingogram in women with surgery, especially J pouch, ileostomies, or people have had their rectums removed, this scarring, the tubes won't work, they're not functioning, they're blocked. So it's like a very, very common thing. And that's why a lot of patients who have had surgery need IVF.
And we have some questions I'm excited to see. So somebody's asking, what about Simponi? That's not listed in the studies.
Oh, yeah, sorry. I haven't seen a lot of pregnancy studies or any pregnancy studies on Simponi, but it should be safe. I don't see why it isn't as safe as anything else. I believe it is transported the same way as Remicade and Humira, so it's actively transported across the placenta. So, wow, the last dose, it's a little tricky because it's every 4 weeks. The last dose should probably be around 32 or 34 weeks, just like you would use Humira. We just don't have a lot of patients on it.
So somebody was asking about the pelvic floor therapy. So we're curious, how does that work? How is that effective for people with UC?
So it's effective for the symptom of dyspareunia, so painful intercourse. It's also effective for other things too, but mainly for the symptom of dyspareunia. And I've seen people with perianal fistulas, with pelvic surgery, just get a lot of pain. And what the therapist does is really like intravaginal pressure points. It's like, you'd have massage on muscles in other parts of your body. And I actually, I shadowed my pelvic floor physical therapist for a day just to see what she did. And it's like a very intimate thing. And women do it, but it's basically intravaginal massage and pressure point therapy, and it can hurt. And she also uses dilators. So they also basically go up in size, and you have to refrain from intercourse, from sex for 12 weeks while you're getting the therapy. But it actually really works. I've had a lot of good luck in my patients with it.
Great. It sounds like, is that somebody that perhaps you'd want to go to your gastroenterologist to get a referral, or is that maybe something your OB-GYN might have a better recommendation?
GI should know. I mean, we do know the therapists in our area. The GYN should know too. I think it's becoming more and more common to go.
Okay. All right. And says, question is, do you have to have a colonoscopy to make sure you're in remission before getting pregnant, or can you go based off of other tests?
It depends when your last colonoscopy was. And if your last colonoscopy was a long time ago and you're not sure, it's probably best just to check. But if you had a colonoscopy a year ago and everything looked great and you're still on the same medication, that's probably fine. If you're worried about colon cancer, like you've had dysplasia in the past, it's best to get it checked out prior to pregnancy. So it depends.
Okay. The follow-up to that, it was mild inflammation 2 weeks ago. Any other changes?
On colonoscopy 2 weeks ago, mild inflammation. Do you feel okay? I mean, if you feel okay and you're not having a lot of symptoms and you feel well, yeah, you can probably get pregnant with mild, yeah.
She says mostly, slight bleeding.
Yeah, no, it's better to be really as in remission as you possibly can on maximal meds. I don't know what medications you're on, but maybe your doctor can increase them a little bit or add a little bit here and there, so you're maybe not bleeding and having foreign bowel movements. So it would be better.
Okay. All right, next question. Have you noticed more women needing C-section with a permanent ileostomy, no rectum? Says, I attempted vaginal delivery but wouldn't progress despite being induced. The thought was that my uterus was tilted due to not having a rectum, so there was less pressure on my cervix.
Wow. We're trying to do a study with that, looking at modes of delivery in women who have permanent ileostomy, so I can't really answer your question, but I know in the few patients I've had, it's been like half and half. And the GYNs always try to deliver vaginally, if they can. And because a C-section can be complicated if you've had prior surgery. But I'm sorry, I can't answer your question. I just don't know.
Okay. So another one of my questions. You mentioned that folks with ulcerative colitis tend to flare more during pregnancy. I'm curious why that is.
Nobody really knows. It probably has to do with inflammatory substances in your body called cytokines. There's probably a very complicated immunology explanation that nobody really understands. So basically, it's shown up like that in every single study I've seen, but nobody really knows. The people who do the worst during pregnancy, however, are the people who are diagnosed when they're pregnant. At pregnancy, that population does the worst.
Okay, so if there's any other questions, please feel free to type it into the box. So I'm curious, you talked a lot about the pros of working with a counselor sort of on lots of these issues. So as it relates to sort of stress management, but also about, body image, those sorts of things. Is there, when somebody was looking for a counselor, is there specific questions they should be asking them? Or have you noticed there are specific techniques like CBT or those types of, cognitive behavioral therapy, for those who don't know it, that might be more effective for folks?
Yeah, that's a really good question. I try to see, is it more stress, anxiety? Is it more depression? I want to have people work with someone who's experienced with Crohn's disease and ulcerative colitis, because it's really hard to understand if you're not experienced with that. So we have 1 or 2 people that tend to treat a lot of my patients. I don't know of one particular therapy that's best. In my experience, my patients have gotten different types of therapies. So I'm sorry, I can't answer that question. I don't think it's known what therapy is best, but definitely go to someone who's experienced with Crohn's and colitis.
Okay, great. Well, I am out of my questions, and it looks like we're out of questions for everybody else. But so I want to thank you again so much for doing this. I think this was awesome information. We've recorded this webinar, so we are going to be posting it onto the North Texas Facebook page, chapter website, the South Texas website, and also the Louisiana website. So if you're not in one of those states, feel free to visit our websites, and you can find it there. I'm going to have it along with the slides. And I'm going to be following up with an email to all of you with a questionnaire, just to ask you some questions about what you thought of the webinar and to get some suggestions from you for future webinars that we're going to plan in the future in 2019. Do keep in mind, I've got another webinar coming up in November. On November 8th, we're going to be talking about complementary and alternative medicine with Dr. Matthew Hand. So I'm pretty excited about that. I know that everybody's curious about that topic. So again, I want to thank you so much, Dr. Friedman, for taking tonight, and thank you all for joining me tonight. Oh, hang on, we got one more question. So let's do one more question, and then I'll sign off. So let's see. We have somebody with microscopic colitis, and no medications are working. So let's see. How dangerous is prednisone during pregnancy?
The baby doesn't see any of it. It doesn't really cross the placenta. So, the mom can get sugar intolerance and high blood pressure, but the baby doesn't really see any of it. So it's very safe for the baby. We actually use it pretty frequently for IBD flares. So it's safe.
Great. Awesome. Well, that's excellent. I'm glad that's a question that we could answer so thoroughly. I'm sure that's a huge relief to our questioner. So again, thank you so much, everyone. Look for this recording, and we are going to sign off for tonight. But thank you so much, everyone.
Thank you.
Bye.